Good afternoon. Welcome to this monthly IMA-AMS webinar. Greetings from Indian Medical Association, Academy of Medical Specialties. Warm welcome to all the leaders and the members of IMA. So thank you for this wonderful opportunity to spread the knowledge across. This is today's invitation. Today we are going to take the lectures of two important topics to commemorate World Alzheimer's Day and World Rabies Day. So we have star speakers. I thank all the leaders of IMA for this wonderful opportunity to spread the knowledge across the India. So this is all the today's CME program and speakers. We'll start the program with the this is the brief program agenda. May I request our Joint Secretary Adar Sindil Kumar to start the program with the physician.
Thank you, sir.
Thank you, Sindil sir. So may I request our Chairman of IMA-AMS TNSB, V. Rajesh Babu sir, for the welcome address. Rajesh Babu sir is a senior consultant, neurosurgeon in the Department of Neurosurgery. He is a HOD in Ganga Hospital, Coimbatore. Dr. Rajesh Babu sir is the former president of IMA Coimbatore and currently is chairman of Organ Donation Committee as well as IMA AMS wing of IMA TNSB. So welcome Dr. Rajesh Babu sir for the welcome address.
Good afternoon, everybody. First of all, I thank our president, Dr. K.M. Abul Hassan sir, our state president, to giving us the opportunity to conduct the IMA-AMS monthly webinar. This is the 9th webinar which we are conducting. I welcome our president, Dr. K.M. Abul Hassan sir. At the juncture, I welcome Dr. Karthik Prabhu sir, our honorary secretary, Dr. R. Gunasagaran, the national vice president sir, Dr. Sendamil Pari sir, immediate past president, Dr. Senguttuvan, the state president-elect 2024, and Dr. B. Sridhar sir, state president-elect 2025, and Dr. Gauri Sankar, the treasurer of IMA. Every month we are having this program on the first Thursday, and every month we are giving some important and doing it. This month we are having the Alzheimer's Day and also the Rabies Day. That's why we have included these two topics. At the juncture, I welcome the speaker of the day, Dr. K. Vijayan, who is a leading neurophysician at Royalcare Hospital, and Dr. N. Syed Mohammed from Sri Kumaran Hospital, Tirupur, and the moderators of the day, Dr. Valavan for the advanced treatment of Alzheimer's disease, neurodegenerative disorder, and Dr. R. Gunasagaran, the vice president, the recent advances in the treatment of the rabies. Thank you, one and all. Jai Raman.
Thank you, Chairman sir, for your valuable address. May I request our state president of IMA TNSB, Dr. K.M. Abul Hassan sir, for the presidential address. Over to Abul sir.
Thank you, Dr. Jaraman. Good afternoon, all of you. I also recognize the presence of National Vice President Dr. Gunasagaran, Dr. Rajesh Babu, Dr. Adar Sindil Kumar, and all my office bearer colleagues of IMA TNSB and the delegates. It gives me immense pleasure to take part in the webinar of one of the most busiest and also very active wing of IMA Tamil Nadu state, that is IMA-AMS. I know that they are very much engaged in other courses also. So in between these webinars also happening. So I take this opportunity to thank them and also thank the faculties, Dr. Vijayan, Dr. Valavan, Dr. Syed Ahmad Buhari, and Dr. Gunasagaran. And the topics chosen coinciding with the Alzheimer's Day and the Rabies Day, we have two topics on the same subject. I think they are not very well discussed in the past. I think these topics being discussed today will throw more lights and giving more messages, which would be directly applicable to the day-to-day practice. So I thank the organizers for giving me this opportunity, and I also wish all the delegates have a wonderful time of the webinar today. Thank you very much. Over to you, Dr. Jairam.
Thank you, President, sir. Now I'll give my secretary's report. I am Dr. S. Jayaraman, IMA AMS Secretary of TNSB. This is my office bearer. Our chairman is Dr. V. Rajesh Babu, sir, and our joint secretary, Dr. Radha.
For the today webinar, the first topic is in the advanced treatment for Alzheimer's disease and other neurodegenerative disorders. I am pleased to introduce our friend Dr. Valavan, is a consultant neurologist, Tirupur Neuro Center, Tirupur. He studied MBBS and MBBS from Kilpak Medical College, MD from Coimbatore Medical College, and DM Neuro from Madras Medical College. He is currently running Tirupur Neuro Center in Tirupur. He got the Vocational Excellence Award by the Rotary Elite in 2020, got the Best Doctor Award by Indian Medical Association Tirupur branch in 2022. He presented various topics in national and state level conferences. He published various articles in indexed journals. We welcome Dr. Valavan, sir.
Thank you, sir. Thank you for your introduction, sir.
Valavan, sir.
Good afternoon, sir. First of all, I want to thank IMA Tamil Nadu AMS wing of Tamil Nadu State Chapter for giving me this opportunity. So today's topic is advanced treatments in Alzheimer's and other neurodegenerative disorders. It gives great privilege to introduce Dr. Vijayan, sir, one of the dynamic and eminent neurophysicians from Coimbatore, from Royalcare Hospital. And he currently working as a neurologist in Royalcare Hospital. He got many awards and many publications for his studies. He was principal investigator for various studies like Parkinson disease, hyponatremia, multiple sclerosis, etc. He has published many research articles in various journals. He was awarded Best Paper Award in INSC 2023. So today he is going to speak about advanced treatment of Alzheimer's and other neurodegenerative disorders. I think it's very difficult to treat Alzheimer's disease. It's very difficult to convince both the patient and the attenders in the neurodegenerative disorders. With this introduction, I hand over the session to Dr. Vijayan, sir.
President, thank you, Secretary. Thank you, Rajesh Babu, sir. Thank you, Valavan, sir. Thank you, Sandil Kumar, sir. And thank you all the participants today for this wonderful CME, where I've been asked to talk about the recent advances in the treatment of Alzheimer's disease. And I thought I'll include other neurodegenerative disorders also, because as of now, the Alzheimer's disease, there is a big boom in both the research as well as treatment.
Very much pleased to introduce our moderator for the next session. The topic is on the recent advances in the treatment of rabies. Our moderator is Dr. R. Gunasekaran. He is the founder and managing partner and physician diabetologist, Deepak Hospital, Trichy. He studied MBBS and MD from Tanjavur Medical College. He finished PG Diploma in Diabetology in Annamalai University, Chidambaram. He has finished his fellowship in Royal College of Physicians, Glasgow, and he has finished his fellowship in Fellow of Indian College of Physicians. He received the Best Doctor Award in 2012 from Dr. MGR Medical University. He received Lifetime Achievement Award in 2017 from Indian Medical Association State Branch. He received Appreciation Award in Doctor's Day 2018 from the Government of Tamil Nadu. He received Ashraf Doctor Day Award in 2021. He held various positions in state and national level in Indian Medical Association and Association of Physicians of India, Coimbatore India Committee. We welcome Dr. Gunasekaran, sir, who is going to be the moderator for this session. Kindly introduce Dr. Buhari, sir.
Thank you.
Yes, sir. Yes, sir. I'm going to open the Buhari.
Thank you, Dr. Rajesh, Jayaraman, and Dr. Radha Sendil, and Dr. Buhari. Today's topic is the recent advances in rabies. Nowadays, in every state, especially in the metropolitan towns and small towns, the street dogs are more and more increasing. It is the responsibility of the government, especially the corporation, city corporation or the town corporation. They have to take steps to curb this menace of the street dogs. The Rabies is one of the vector-borne disease, especially it is mainly spread by the rabid dogs, as it is in the household. Most of them are pet, having pet as a dog. Sometimes the wild animals like fox and bats can also spread. Graduated as an MRCEM, that is emergency medicine from the Royal College of London, and MD critical care medicine, VAMS Salem. He is a gold medalist. Course director in Sri Kumaran Hospital Institute of Paramedical Sciences, affiliated to MGR Medical University, Tamil Nadu, unit of Kumaran Hospital of Tirupur. State Council member of Indian Medical Association from Tirupur branch. The Best Doctor Award for Academic Excellence by IMA Tirupur branch on the occasion of Doctors' Day celebration of Southern Rotary Club, Rotary Hall at Tirupur during 22. Prema Ravi Rotary Memorial Award, Excellent Service. He got it for the emergency medical care through Rotary. Faculty speaker in Asian Conference on Emergency Medicine. Chairperson and panelist and speaker for many national and international emergency conferences and workshops. He got numerous publications and research papers under his name, and I wish him all the success in his future endeavor as a critical care physician, and he will enlighten us about the recent advances in the rabies management. As the time goes now, the rabies immunization program also has a little modification, and also the treatment modalities also now it has become different. So we are ready to hear from Dr. Buhari about the rabies. Thank you.
I start in the name of Almighty God. I pray God to make this session beneficial for all of us and the mankind at large. At the outset, I would like to thank Tamil Nadu IMA State AMS for giving the opportunity to present in front of many eminent people who have joined this session. Thank you, dear President, Secretary, and all the office members of the state and the AMS. And I also humbly thank Dr. Buhari sir for humbly accepting to be the moderator of the session. As the senior in the field, the moderator has rightly pointed out the importance of knowing rabies in the current scenario. We are getting a lot of, get to see a lot of videos in WhatsApp where we see the dogs, domestic dogs are no more domestic. They are wide enough to attack children and elderly and fragile people. We see a lot of videos where they are almost like wild animals. So at this juncture, it is our responsibility to know the current stand about the rabies. We see look into little basics, and also we'll see how we could possibly be better in our management. So before I proceed, I wish you all a happy Teachers' Day. I know each and every one of you seniors have participated in delivery of knowledge and to the place where we have reached is all because of you. Happy Teachers' Day.
Thank you, Buhari.
Thank you, sir. So I'll like to cover the session. Basically, I'll just touch on the basics and then move on to post-exposure prophylaxis. As dear doctors, you all should be aware that rabies is a highly fatal disease. So once the disease is onset, even in the current century of modern medicine, we do not have any promising, proven medical management or any kind of management for that matter to give us splendid results patient is going to die invariably. So let us look two important facts which WHO says. One is rabies spreads to people. Yeah, that's all fine. I think we all know about it. Just concentrate on the last line. Once the clinical symptoms appear, rabies is virtually 100% fatal. So if you think that COVID was a dangerous disease worldwide, if you look at the case fatality rate, rabies will win over it like by 100 times. So let us look into the next point, which WHO says. Next is human rabies is 100% vaccine preventable disease. So from 100% case fatality to 100% vaccine preventable disease, but it continues to kill because of lack of awareness or lack of the fear of rabies or fear of rabies vaccine. We all know that rabies will cause hydrophobia and aerophobia, but there is something called rabies phobia, rabies vaccine phobia, and there are a lot of doubts among clinicians whether to give the vaccine or not, or there are any issues, will I get a reaction, can I give immunoglobulin or not, what if the patient misses the vaccine and comes to me, and all those things. So I hope I clear these things by the end of the session. So another important point is anaphylaxis or severe allergic reaction to the post-exposure prophylaxis are very, very rare. Almost nil, we can say, less than 0.01%. So with this background, with this notion, with this positive thing, we can approach rabies, I feel. So as I previously said, we do not have much management that is promising for treatment of rabies once the disease is onset. So it's always better to know the basics, because when we know the basics, someone or the other will definitely try the loophole and they'll find where to attack this virus once it has entered the neuro system. So this virus from the Rhabdoviridae family is a classic RNA Lissa virus. It's neurotropic, so it goes through the neurons, it travels through the neurons. The common mode of transmission, we all know that it is the saliva of infected animals. The reservoirs in our country, the commonest reservoir is the dog. And of course, any mammal can take this virus, and birds and reptiles do not spread it. So we can be safe with them as far as rabies is concerned. In US and the West, the sylvatic from the wild, and especially the bat, it's very, very common. So bats, they say if the bat is going to lie inside your room, just simply also, you should suspect rabies. So it's as important as that. So all wild animals can spread rabies, domestic animals, so mammals for that matter, of course, including humans. So human-to-human transmission via saliva is rare, but possible, theoretically possible. So in case there's going to be some rabies features from the person who has spread, then naturally the same post-exposure prophylaxis has to be on. And the very common mode of transmission in human-to-human is the organ transplantation. So we should be very careful. So because most of the organ transplant patients are on immunocompromised state by some kind of immunosuppressants, so they are very, very prone for this rabies virus from organ to organ. The incubation time goes from 4 weeks to 12 weeks, and mostly not more than a year. So there are cases which has been reported to up to a year. So there are also cases where in China, one patient who was bit by a rabid dog, he went on to take a post-exposure prophylaxis, and that person's saliva for some reason fell on a wound of a normal person, and that person neglected post-exposure prophylaxis, and that person died of rabies. So the post-exposure prophylaxis is very, very important. So whenever in doubt, that is why I put that slide in the first, because there's no abnormal reactions we should fear from the post-exposure prophylaxis. So whenever in doubt, it is better than to risk the rabies. This rabies virus, though it's so terrific virus, but it is easily inactivated by soap, water, povidone, anything. That it is a cleansing agent. The point of interest this mammal, opossum, this has got a very low temperature in its body that doesn't allow the rabies to live or replicate. So this is free of rabies, though it's a mammal. So one point of interest here for researchers in future may be coming down on the temperatures once the patient shows the sign. So we already use the therapeutic hypothermia for patients who are post-cardiac arrest patients for brains survival, brains rejuvenation. So of course, I think hypothermia could be a possible loophole for this rabies management in the future, not now. So let us look into the pathway of how the rabies virus travels. So once it inoculated into the skin, then it travels into the peripheral nerves. From the peripheral nerves, it travels around 20 millimeter per day. So 20 millimeter per day, once it reaches the neuromuscular junction, the inoculum then incubates there for the period of 1 to 3 months. When this thing goes up to the ganglion in the spinal cord, the speed ends. So it is like us entering starting from the house, then slowly going and reaching the NH. So once it reaches the ganglion, the travel rate, the speed of travel is 200 millimeters per day. So what is the significance of this is, for example, a patient is going to get a bite over the head and neck. Then the speed of the rabies is reaching the central nerves is going to be very fast. And likewise, the children who are short statured, the easiness of the virus to reach the spinal ganglia is going to be very, very fast. So that is the clinical significance. So what happens once it reaches the spinal ganglion, a hallmark clinical finding occurs, the pain at the site of inoculum, because the nerve, the dorsal root is received and the pain. So there is some paresthesia at the site, and there's some induration, some kind of a pain at the inoculum site. So this is hallmark. Beyond this point, rabies is uncontrollable. The disease is onset, then it reaches the central nervous system. From there, it spreads to the salivary glands. Again, the patient starts infecting others, and it reaches the nerves, and again, there is a neuromuscular blockade and symptoms go on. The point of interest here for researchers is this point. So because the rabies, though it is neurotropic, it doesn't damage the neurons. It is actually the neuromuscular blockade. So we know that there are plenty of neurotransmitters like acetylcholine, glycine, we have GABA or inhibitory, stimulatory things. So depending upon the stimulation inhibitory, we can have dumb or furious rabies. The point of interest here is if we can go and intervene here, because it doesn't damage the neurons, even when the patient is going for the complete coma, the neurons are not damaged. Though there are Negri bodies, which are cytoplasmic inclusion bodies in the nerve cells, the rabies does not damage the neurons. So if the binding action could be reversed, likewise, just think an analogy to the pralidoxime, which is used for acetylcholine esterase, anti-acetylcholine esterase poisoning, OPC. So if we can get something like that, so probably even after reaching the ganglion, we could possibly recover the patient. So that is going to be the point of research, the patient. So this is the classic Negri bodies, just a nostalgia for microbiology. So just really features about the diagnosis. So history is very, very important, as like any other case. We should look at the incident, how it happened, was it a was it a bite and run? Was the animal available or not? What was the animal behavior? Very, very important. So basically, we can get bit by two types of animals. So one is a wild, the other is a domestic. So what is the difference to deal with this animal is that the wild animals are usually not available for observation. So when we are bit by a wild animal, if it is available, usually it is given a euthanasia, killed, the brain is done a biopsy to see if there are Negri bodies. In that case, the patient should go for post-exposure prophylaxis. If the animal is bit and run, then naturally we should go for post-exposure prophylaxis. If it is going to be a domestic animal, So which is vaccinated animal we have at home. We are very, very confident. So we can observe the animal for 10 days. If there are any symptoms, no issues at all, we can avoid post-exposure prophylaxis. In the case of domestic animal who develops a symptom of rabies within 10 days or so, then naturally we should go for post. So the animal behavior, availability, vaccine status is very, very important in history. Symptoms, usually, I said it is 1 to 3 weeks duration so what happens during the incubation? Usually it starts like flu-like symptom. There is fever, tachycardia, there is tiredness, lethargy, and so on. And as I said, once it reaches the ganglion, so from the peripheral nerves, then you have that paresthesia and pain at the inoculum site, which is very, very classical in 70% of the Sylvian rabies, which is bite bats. Bite dogs, up to 30 to 40% of the people get this pain. So this itself should raise the idea of rabies. Then next, the patient goes for a central nervous system damage. So as I said, depending upon what kind of the neurotransmitter is being blocked or initiated, may be furious or dumb rabies. So by 10th day, patient will go for coma, after which patient goes for. So in furious rabies, we all know that patient is restless, agitated. Patient is not able to even drink water. There is aerophobia, there's hydrophobia, convulsions, and so on. Dumb rabies, again, it is like in animals also. Whenever an active animal, domestic animal, suddenly goes for a dumbness, suddenly go for lethargy, we should be very, very careful. That could be possibly a rabies. And also, when the patient is very, very silent and not very apathetic and not obeying and so on, we should think of dumb rabies. So usually furious rabies occurs in 2/3 of the patients and dumb rabies occurs in 1/3 of the patient. And by 10th day, patient invariably lands up in coma and death is end result. So from examination, there's classic hydrophobia and aerophobia. I don't know, many of us wouldn't have witnessed this at all because of the participation by all the healthcare professions by rightly giving the post-exposure prophylaxis at the right time. But this classical hydrophobia and aerophobia, if it is there, the diagnosis is very imminent. And there could be possibly other signs, constitutional signs. So one important point to note here is sometimes because of the meningoencephalitis of this neurotropic virus, there can be anisocoria. Sometimes patient may mimic pseudo brain death. So because there is severe vasospasm of the cerebral circulation, sometimes EEG also may not give us a good idea of the brain death of the patient. So we should be very careful before declaring brain death because there could be nuchal rigidity, patients in coma, anisocoria, respiratory failure, all in favor of brain death. But we should be very careful before we declare brain death because of the severe vasospasm of the cerebral circulation. So few points about workup before I quickly move on to the important post-exposure prophylaxis. So the specific DDs, any kind of encephalitis causes maybe viral, bacterial, fungal, TB, tetanus, poisoning, Guillain-Barré syndrome, prions, all are DDs for rabies. So investigations in rabies is very clinically diagnosed. When in doubt, there are a few things like skin biopsy is very, very pathognomonic because the peripheral nerves are taken and then look for negative bodies. So it is usually taken from the nuchal area, nape of the neck. We look for rabies antigen. So corneal touch impression antibody, not much used, but just a point of interest. And there are also possibilities for cultures and PCR from saliva and CSF. CSF usually like in GBS, so that is the DD for rabies, encephalitis. It's usually acellular. There may be certain monocytosis, but usually it's acellular. Again, to confuse the picture. So other investigations are blood gas analysis. When patient goes for tachypnea, initially they may have respiratory alkalosis, and then they go for respiratory failure. They go for acidosis. Again, it is not going to be diagnostic, There is one MRI finding which was consistent because of the ganglion. We saw that the ganglion deposition and that incubation at the ganglion. There is a T2 enhancement in the MRI that, and EEG, as I already said, it is not representative of the brain death because of the diminished circulation due to vasospasm. And cerebral arterial flow is very, very important before we declare the brain death, because cerebral arterial flow will be completely absent, only by which we can then tell the patient is brain death. Of course, brain biopsy is an investigation of choice, but post-mortem. So newer focus are there. There are a few settings coming up, like NASBA, nucleic acid sequence-based amplification, which is done within 2 days in the urine sample. So when in doubt, this may become positive, though it is not universally available. And the rapid fluorescent focus inhibition test, which detects the antibodies to rabies virus from CSF or any other body fluid. So basically, the RFID antibody in rabies patient, if the patient is going to be a rabies patient, patient would have succumbed to coma before the development of this antibody. So it may not help in the rabies. It may rule out. It may not rule out, or it may not be diagnostic. So, but it is a test where we can know the antibody response due to vaccines. So that is a for few cases we need to know, which we'll be seeing when we look into the vaccines. So coming to the post-exposure, I think this is a very important step we should follow. Once we get a patient with a rabid bite by the animal. So extensive wound washing with water and soap, or we have 15 minutes is very, very important. This is the recommendation by WHO. So if there are any foreign body, if there are any tools, the careful removal should be done. We should never suture suspected animal bite. We should allow it to heal by secondary intention. Otherwise, we would lock the organisms inside. And tetanus toxide, depending upon the type of and the vaccination status, and tetanus immunoglobulin, depending upon the extent of injury, can be administered. Antibiotic prophylaxis, depending upon the contamination of the wound, mostly beta-lactam would be sufficient. So the risk assessment, the WHO has given 3 main categories. The first category is no exposure, just touching and feeding animals. So for them, on intact skin, no problem. No PGP is needed, washing is enough. Category 2, there is lifting of uncovered skin, minor scratches or abrasions without bleeding. So there is an exposure, but the scratch, wound washing and immediate vaccination is advised. Whenever the skin is broken, a simple break, blood is seen, and there's a lot of scratches and animal licks, then definitely wound washing, vaccination, and rabies immunoglobulin or monoclonal antibodies should be administered. So there's just 3 categories: no exposure, simple touch, no issues; minor abrasions, vaccination, washing. If the skin is abraded, go for both passive and active immunization. So let us look into the how will we proceed with the patient's post-exposure prophylaxis. So we have looked at the vaccination status of the patient. So if the patient is not vaccinated before by an anti-rabies vaccine, then naturally they have to be given vaccine. If the patient had received it before, for example, 0, 3, 7th day, 14th day, but patient has not completed the course, then again, they fall into the category where they should be given the post-exposure prophylaxis. And if the vaccination status is not known, or if the vaccination status is more than 5 years, then we should go for a post-exposure prophylaxis. So we should be giving, depending upon the category of wound which we saw in the previous slide, we should give both human recombinant immunoglobulin, rabies immunoglobulin, and the rabies vaccine. So patients who are vaccinated before for the full schedule, that is the 0, 3, 7, and 14th day, and they present after 5 years, of course, they will have antibodies. So only vaccine is sufficient for them. For all the other categories, so no vaccination, vaccination status not known, or the patient has an incomplete vaccination schedule in the prior history, then we should be giving both immunoglobulin and vaccine if warranted. So if there is a suspicion, as I said previously, if there is a suspicion, the things are not clear, and there is no harm in going ahead, if especially when the wound is big, and especially when the bites are more, and when the children are involved, then we should go for human rabies immunoglobulin and vaccine without any second thought. So what is the dose of human rabies immunoglobulin? So usually it is 20 international units per kg. How are we giving it? We will take and give as much as possible at the inoculum site, and the remainder should be as IM, and it should be distant from vaccine administration. For example, the vaccine was given in the right deltoid, try to give the remainder of the immunoglobulin at the left deltoid. So that is on point. For children, the volume of immunoglobulin may be very low to be given at the inoculum site, because the inoculum site should be infiltrated very well. So we need to dilute with normal saline and increase the volume, then administer the maximum possible dosage at the inoculum site. So there is one more passive immunization, which is the rabies human monoclonal antibody. The dose of that is 3.33 international unit per kg per body weight. So few doubts on human rabies immunoglobulin therapy. What if the patient presents late to us? So if the patient had a bite and presents to us until 7 days, we can give both human rabies immunoglobulin and vaccine. If the patient presents beyond 7 days, giving human rabies immunoglobulin is not warranted, because the problem is, if the patient is going offer a rabies vaccine, the immune response will be very, very blunted. So not beyond 7 days after exposure. Pregnancy is not at all a contraindication for human rabies immunoglobulin we can give. And for immunocompromised individuals also we should be giving. So these are the main individuals who should receive human rabies immunoglobulin. So there is no doubt, there are no contraindications, they are actually indicated. And allergies, very, very rare. For of course, we should be ready whenever even pantoprazole can cause allergy. So we should be keeping the drugs for allergy ready with us, adrenaline and antihistamines and steroids always ready with us. So coming with the rabies vaccine. So the dose of rabies vaccine, it is the inactivated rabies vaccine, which is available commonly for us. There are other types also, like the purified chick embryo vaccine and all, which we don't use. So this is the vaccine which we use, which is the dose of it classically is 1 ml intramuscular and deltoid. So it is usually given on 0, 3, 7, and 14th day. So these 4 doses will elicit sufficient immune response. It is so much so that it is nearly 100% positive. It will definitely elicit a good response, and we need not even check the antibody titer if this is done properly. And we can consider the day 28 dose for immunocompromised individuals because their immune response may be blunted. And few clarifications on human rabies vaccine. One thing is, if the patient is vaccinated for 14, for example, patient had the vaccination before 0, 3, 7, and 14, and now comes with a new exposure less than 5 years. If the patient comes within 3 months, we need not repeat the vaccine. If the patient comes with between 3 months to 5 years, that is after full vaccination, then they can receive only 2 doses, which is sufficient, no immunoglobulins, day 0 and day 3. So this day 0 and day 3 will propagate the anamnestic response for the previously administered vaccines. And pregnancy, again, it's not a contraindication for human rabies vaccine. For immunocompromised individuals, we can definitely give human rabies vaccine. Of course, sometimes if we are not sure about the antibody response, then we can actually check the antibody response 2 to 3 weeks later after the last dose. In immunocompromised, it's usually the 28th day. So allergies, very rare. So we should keep the drugs ready. Yes. So next few clarifications. So if the patient is vaccinated till day 14, new exposure in 5 years, as I already said, is only day 0 and day 3. What if the patient is immunocompromised? So as I said, we should check the RFFID titer, so the fluorescent antibody titer, 2 to 3 weeks after the last dose. So when in doubt, if we have a doubt if this vaccine has elicited a good response, we can do this. But it is 100% effective for immunocompetent people. For immunocompromised people or patients who are like this, who miss the doses often, like they take 0 dose, they come for 10th day, they take irregular dosage, they do not take the regular dose at 0, 3, 7, and 14. Then for them also, we can check the titer 2 to 3 weeks after the last dose. So this is a scenario where when the patient misses the dose on day 7, he comes on day 10. So what to do now? So when to give the dose? It's on day 14th or what? So we should give the next dose on day 17. That is usually the difference between day 7 and 14 is 7. So add 7 days to day 10, which is day 17. So the next, so likewise, if the patient takes the dose on 0 and misses the dose on 3rd day and comes on 5th day, then we have to take the next dose on 9th day, not on the 7th day. So just follow the difference between the usual doses. And we can check antibody titers if there are a lot of lapses in the schedule. And gluteal IM injections are not at all recommended because they elicit very poor immune response. Because what we have in hand is the human rabies vaccine. We should not waste it. Never ever give gluteal IM of human rabies vaccine. There are no diet restrictions when the patient asks about it. So beyond this, in case the patient lands up in rabies, then just look into what are the inpatient care available. Of course, as I already said, the case fatality rate is 100%. Invariably, the patient will die. So there are no scientific consensus available till date. So we do not have any proofs. There are no proven data. They have tried therapeutic coma for a few patients. There was one patient who recovered, but it cannot be recommended because of the lack of stability and reproducibility in other patients. And cerebral vasospasm can be managed with nimodipine, but the problem is, as I said, the rabies virus goes retrograde to the central nervous system and comes antegrade forward. So it also causes autonomic instability. So if we are going to use nimodipine on inpatient care for cerebral vasospasm, then again, hypotension will be an issue. So again, that is also not there. Steroids, very much contraindicated for animal bites. So there's no proven data. And there are this group of constitutional therapy coming with ribavirin, interferon, ketamine, immunomodulation. And the study is not validated so far. So we need to get much more data before we could possibly make this happen in our patients to save them. So thank you all for patient listening.
Thank you, Dr. Buhari. You have explained in detail about the rabies, especially this fatal disease, canine-borne disease. It can be prevented. Once if encountered, it cannot be treated, and definitely encountered without a vaccine means definitely it is a fatal, as you have told. And also the recent immunization schedule, immunoglobulin, and as well as the vaccine modality also you have explained in detail. I should congratulate and thank you for the wonderful lecture. Few questions are there. Can I?
Yes, sir.
Yes, sir.
Does all the bites leads to dog bites leads to rabies?
So it depends upon the patient is the dog is domestic or whether it's a vaccinated dog which we keep at home or it's a stray dog. So if it's going to be a stray dog bite and run, then naturally the animal is not available for observation. That is a problem. So naturally we should go for post-exposure prophylaxis. If we can catch the dog and observe if there are any rabies signs of rabies, then naturally we should go for post-exposure prophylaxis. In vaccinated dogs, usually we need not be afraid because they also have a very good immune response. So once vaccinated, they can also receive a booster up to 5 years. The dogs, if they're that much age is possible for the dog, then we need not receive a post-exposure prophylaxis. So it depends on what type of dog is with the patient.
What are all the precautions taken by the healthcare authorities after the death due to rabies?
Sir, because rabies is an infectious disease, in case we encounter rabies, it should be highly isolated, and we should have an infectious disease isolated room, and we should also definitely report it to the authorities. And once patient dies, I think it should be completely done under the post-mortem examination should be done with high end safety equipments and safety measures at the government, the regional government hospital.
Okay. How safe the vaccine in pregnancy in all trimesters?
So it is completely safe. We can give both the vaccine and the immunoglobulin without fear.
All
Yes,
trimesters.
he has put slide also. Slide also shows that in pregnancy it can be given.
Okay, sir.
It should be.
Is brain is the target organ in rabies? Only brain? It's a question from Dr. Sundarmurthy.
Sir, it's a neurotropic virus, sir. So it travels all the way. As I said, once it reaches the ganglion, it's so fast that it reaches the brain. So the target is the brain, and from there it spreads elsewhere. So, but the problem is it doesn't damage the neurons. It is the neuromuscular blockade. So junction is the problem.
Okay. ARV around the umbilical region is still in practice?
Sorry, but the brain goes for damage because of reflex vasospasm. There's severe vasospasm. There is no direct injury.
Okay. Dr. Gunasaran, sir, do you want to add any more thing regarding the question?
Few more questions, Sirka?
Yes, sir. ARV around the umbilical region is still in practice or not?
No, sir.
Not, okay.
Can the vaccine be given anterolateral aspect of thigh input?
Yes, sir. It can be given, sir. Only
sir, previously they were giving anti-rabies vaccine in government hospitals and all those things. That the Kunur vaccine, that is still it is available, or it is totally taken off from our curriculum itself, and it is not in the pharmacy itself. Whether it is still available?
Sir, it is. I'm not sure, sir, but in the intradermal dosing, we are not using now, sir. As far as I know, only IM, the inactivated human rabies vaccine is used, sir. Actually, only for the cost purpose, those things were actually developed. But now, even in government hospitals, they are giving IM injections.
If dogs are involved in research purposes, steps taken to prevent from rabies?
Yes, sir. It's a very good question, sir. Actually, it is the pre-exposure prophylaxis, which I didn't actually touch because of the want of time. Those people who are doing research with dogs and other animals who could possibly extract the virus from the animals should go for pre-exposure prophylaxis. The pre-exposure prophylaxis is usually 2 doses, which is day 0 and day 7. So that is enough.
7.
Yes.
From Dr. Rangarajan, schedule 28 and 90, it is not there now. Now it is only up to 14 days. Optional is 28. Is it not, sir?
03714 is enough, sir.
Yes, enough.
Yes, sir.
Golden days, we give at 60th day. That is not there now.
Yes, sir. You are
So we
very
can give 03714. That's enough, sir.
14, that's all. But optional 28 is there for immunocompromised individuals, as Buhari has already explained.
Yes, so rightly said. So throughout studies, they have found that the 28-day vaccine did not in special rise anything higher than 14th day, sir. So as you said rightly, 14th is enough. Yes.
There is one question from Dr. Ragarajan. The bedding of the patient is to be burned, and is it free from contamination?
So I didn't get you, know.
The bedding should be burnt. Bedding of the patient, rabies patient, should be burnt or not.
It should be-
Bedala.
Sir, we should dispose it like we dispose any other biomedical waste, sir. It's not
Better it should be disposed or burnt.
yes,
Better.
Yes.
Good.
Thank you, sir.
Thank you, President sir. Thank you, Secretary sir of the IMA, State IMA. Thank you, everybody, for giving me this opportunity to talk on recent advances in the treatment of Alzheimer's disease and Parkinson's. Now, I added Parkinson's because I added neurodegenerative diseases to the list of treatment modalities, because there is a new treatment which is common for both Alzheimer and Parkinson's disease. The basis of this new treatment is the blood-brain barrier. Most of our drugs do not cross the blood-brain barrier. That is the reason why we are not able to penetrate and treat these various neurodegenerative diseases. This base introduction to Alzheimer's disease, epidemiology, dementia research, Alzheimer's disease genetics, the new era of biomarkers in Alzheimer's disease, amyloid imaging, new criteria for the diagnosis, disease modifying treatment, and the future. It's a multi-system related neurodegenerative disorder, and there are several forms of dementia. The commonest is Alzheimer's dementia, and the second commonest is dementia with Lewy bodies. Of course, all the others come a little late. Vascular dementia is one, and we do see a few cases of Creutzfeldt-Jakob disease also now and then. Hello. The epidemiology of dementia. The number of people living with dementia worldwide is 2015 is estimated at 47 million, which reaches 75 million in 2030 and 135 million in 2050. The prevalence rates varies from different regions in India, and they differ widely. In the southern parts of India, it's around 3.6 to 4%. This is the same which is seen in somewhere in the east of India also, from the west of India also. But if you go to the east of India and northern India, you see a slight decrease in the prevalence rates. The reason, I think, is skewed. The reason is basically a sampling error, because most of the areas in the south and the west of India are fairly well developed, literate, and hence the awareness of Alzheimer's disease is quite high. While in the east of India and north Indian India, especially the so-called BMRO states, the literacy level is little reduced, and hence sampling error is there. Probably it should be the prevalence of dementia in India in 2010 is between men and women is shown in this bar diagram. You can see women are slightly more affected than men. Basically, this is due to a hormonal lack, especially in the postmenopausal women, and thereby that adds to the increased dementia burden in these persons. Long-term studies and dementia and cognitive dysfunction are very few from India. In one study from North India, Alzheimer's disease showed an incidence. I told you it should be around 3 to 4%, 4.7% per 1,000 years, as compared to 17.5 per 1,000 years in USA. Another incidence study in Dogra population documented an incidence rate of around 5.34% per 1,000 person years. The rapid increases in the number and proportion of older people are forecast for China, India, and Latin America. By 2050, the number of people aged 60 years will have increased by 1.25 billion, accounting for 22% of the world's population, with 79% living in the world's less developed regions. The estimated number of people with dementia, this bar diagram shows by the end of 20, it's a staggering 14.32 million. The estimated number of people with dementia in India, UK, and USA. You can see the numbers are rapidly rising in India towards 2050. That is due to primarily increase in the older population. The protective factors for dementia, cognitively stimulating activities across the lifespan, regular physical activity, higher engagement in leisure, social activities, higher education, light, moderate alcohol intake, and fish intake. The risk factors are increased age, as we know, genetic factors, apolipoprotein A, which we almost, so many other genetic factors, we'll see them one by one. A family history of dementia, underweight and overweight, including obesity, smoking, hypertension, elevated cholesterol, high intake of saturated fatty acid, diabetes, stroke, heart disease, traumatic brain injury, and depressive symptoms. Now, regarding this moderate alcohol intake, I would like to share a few words here that in the Indian population, this has shown to increase the risk of dementia. Alcohol overall throughout the world has shown to decrease. Moderate, mild to moderate consumption has shown to decrease the incidence of dementia, while Indian population, it has shown to increase the risk of dementia. So even a little bit of alcohol is not good for the Indian brain. The preventive strategies for dementia are an active social life, regular exercise, healthy diet, mental stimulation. That is, for example, you can play Sudoku. Quality sleep and stress management. Quality sleep, again, stress on quality rather than quantity of sleep. Anything up to 4 to 6 hours is enough, is essential and enough for the human brain to rejuvenate itself. The genetics in 1920s, inherited forms of Alzheimer's disease were recognized. 1991, the first pathogenic mutation in amyloid precursor protein, the London mutation, was discovered. 1993, ApoE4 was considered a risk factor. It's still a risk factor, especially when it is present in both alleles. In 1995, presenilin 1 on chromosome 14 and presenilin 2 on chromosome 1 were recognized. In 29, the genome-wide association studies have thrown up a large number of genetic markers for Alzheimer's. ApoE4 is, however, the strongest risk factor. You can see that 3 times with one allele and 9 times with 2 alleles. In the genome-wide association studies, it showed all these genetic abnormalities. In all these are involved in cholesterol metabolism, complement cascade. So these offer newer targets for the treatment of dementia. This is how the amyloid cascade progresses. Basically, you get APP processing into A-beta, amyloid beta aggregation, and this results in the classical neurofibrillary triangles, which interferes with cell dysfunction, promotes the cascade of apoptosis, and finally cell death and degeneration. That is how you lose your brain. So basically, use your brain or otherwise you will lose it. The new era of biomarkers in Alzheimer's disease, you have MRI, CSF, and of course PET. Now, these are the guidelines for structural imaging. MRI is the preferred modality, but in places where MRI is not available, nowadays is available almost everywhere. Clinical symptoms appear are amyloid beta 42, FDG tau proteins, hippocampal volume, and all the other markers, which will go one by one. Now, the model for dynamic biomarkers in Alzheimer's disease is amyloid beta accumulation, synaptic dysfunction, which can be documented by FDG, PET, MRI, tau-mediated neuronal injury, again documented by CSF measurement, especially the ratio of A-beta 142 to tau, phosphorylated tau, brain structure, volumetric analysis, especially the hippocampal volume, the amygdala volume, and the entorhinal cortex, volume of the entorhinal cortex. Finally, cognition clinically, and clinical function, from minimal cognitive impairment to mild cognitive impairment to dementia. The changes in core CSF biomarkers in MCI, and that is minimal cognitive impairment, and Alzheimer's disease appear to be almost the same, but not all minimal cognitive impairment progress to Alzheimer's disease. Only 1/3 of them progress to Alzheimer's disease. The remainder remain as minimal cognitive impairment. Now, what is the difference between minimal cognitive impairment and Alzheimer's? Say, for example, if you forget something and you forget it, and if you're reminded of it, you suddenly recollect it. You say, yes, I do remember it now. Then that is minimal cognitive impairment. Now, these cases have to be watched carefully. Maybe you can also measure their hippocampal volumes, which is very easily available nowadays. And you can follow up these patients so that they don't develop, and give them lifestyle modifications, engage them in an active lifestyle, use their brain, make them to use their brain like games, reading, Sudoku, etc. and etc. Fruit supplementation in the diet, avoid alcohol, avoid smoking, and all these factors will help to prevent MCI from going into Alzheimer's disease. So that is a more important thing. And you can also, if you have advanced facilities, of course, do an amyloid PET imaging to look whether this MCI will turn out into AD. Most of MCIs that turn out into AD will show up early on amyloid PET imaging. Now, at the diagnosis of AD, the hippocampus volume is already 10 to 20%. That is a hippocampus. You have the amygdala and the entorhinal cortex. These volumes can be measured regularly. Baseline 18 months, 30. You can see the progressive decline in volume of the hippocampus and the amygdala. This is the amygdala. Again, you can see a progressive decline in the volume of the amygdala. CSF in this is imaging. Then CSF shows a reduced A beta 1 to 42 in controls. Versus controls. The tau is increased. The tau protein is increased more than 2 times versus controls. More important, as I told you, the tau A beta ratio. The phosphorylated tau protein to A beta ratio is increased more than 1 and suggests AD. Good sensitivity and specificity versus controls, but also you must remind that CJD and FTD also have increased tau levels. Of course, they are very easy to differentiate when you have a clinical diagnosis of Alzheimer's disease also. Amyloid imaging, this is using the Pittsburgh compound B. Now you can see that in AD versus the control, the compound binds to the amyloid, thereby giving this appearance on PET CT imaging. Amyloid CT in MCI that has converted to AD, and amyloid in imaging in MCI that is not converted to imaging. I told you there is a difference. Only 1/3 of MCI, minimal cognitive impairment, converts to AD. The new criteria for earlier diagnosis, again, more and more it relies heavily on clinical criteria. There should be a gradual and progressive change in memory function. So first to be affected is a memory reported by the patients or informants over a period of more than 6 months. So it should be progressive and it should be a gradual decline. These two things should be always, we have to keep a note of this. Objective evidence of significantly impaired episodic memory on testing. This generally consists of a recall deficit. Usually you ask them words and ask them to recall those words. That does not improve even on queuing. If it improves on queuing, it is minimal cognitive impairment. If it does not improve on queuing, it is early Alzheimer's. The episodic memory impairment can be isolated or associated with other cognitive changes as the AD advances. Now, the supportive features. So primarily the diagnosis is clinical. The supportive features, presence of medial temporal lobe atrophy, as I told you, volume loss in the hippocampus, amygdala, and entorhinal cortex, which can be carefully measured, and also every 6 months on MRI images. Abnormal CSF biomarkers that we told you, a low amyloid beta 1 to 42 versus an increase in the phosphorylated tau, and especially a tau amyloid beta 1 to 42 ratio, and a specific pattern on functional neuroimaging with PET. All these using the Pittsburgh compound B, which is not available at present in India. The disease modification AD beyond cholinesterase. So all these years we have been harping on only cholinesterase inhibitors for management, though they are very good drugs. We tend to introduce them in the minimal cognitive stage itself, that towards the when we know that the progression of Alzheimer's is starting clinically, we start introducing them. Symptomatic treatments now with wider NICE guidance have modest benefit. Increasing concerns about neuroleptic use. Avoid neuroleptic use in elderly. avoid especially use of antidepressants in elderly. If you use antidepressants, you are going to worsen most of the dementias in elderly. Most of the time, you may worsen the dementia, you may also increase the fall. Another thing is also to document any sudden worsening in AD. In sudden worsening in AD, this could be due to a new vascular insult. This could be due to a seizure also. So EEG nowadays is now playing a big role in the monitoring of Alzheimer's disease. If a stable Alzheimer's disease suddenly deteriorates on the scale, on the clinical scale, get an EEG done. If this patient shows epileptiform abnormalities, now these patients are suitable candidates for even anti-seizure drug therapy. Now that improves their cognition. So this is something new as far as AD is concerned. Another thing that is very new in AD, which is not very new, but which we fail to recognize, is what we call CARI, or amyloid associated inflammation. Amyloid associated inflammation, which is sometimes causes a rapid deterioration in the patient's sensorium. Patient may become suddenly irritable, delirious, and then become comatose and also convulse. So in such patients, a short course of steroids will rapidly improve. This is cerebral amyloid angiopathy related inflammation, or CARI, which time and again we have seen these cases. Always look for a vascular insult, always look for an infection, always see whether there is CARI in these patients. And if none of this is present in a patient who is rapidly deteriorating, get an EEG done. If EEG shows epileptiform abnormalities, anti-epileptics will help this patient sometimes in improving their cognitive level. Do not use neuroleptic medication in elderly patients. Do not use antidepressant. It increases the number of falls also, and it worsens the cognitive status. What are the newer ones? Anti-tau therapies, gamma secretase inhibitors, amyloid immunotherapy, and others. Now, this is a amyloid plaque in transgenic mice prevented by immunization against A beta. This is A beta 42 treated hippocampus, which does not show any amyloid deposition in rat, and this is that one. Now, vaccines are available in phase 1, phase 2 studies. There are some gamma secretase inhibitors and beta secretase inhibitors which have undergone clinical trial. And nowadays, there are also monoclonal antibodies against amyloid. These are the anti-amyloid therapies. So many anti-amyloid therapies are there in the pipeline. And the latest one is the aducanumab. Aducanumab is a monoclonal antibody against the amyloid. And when used alone, though it showed reduction in amyloid burden in the brain, it did not show any significant clinical improvement. Now, for this, what we use nowadays is to open up the blood-brain barrier. We know that most of these drugs do not enter the brain. That is the reason for their poor clinical outcome. So, a phase 1, phase 2 trial of opening up the blood-brain barrier is now in vogue. It is already started, and it has shown some wonderful results in the initial phases. Like, it has shown significant reduction in the amyloid burden in the areas where the blood-brain barrier has been opened up. And what do we use? We use focused ultrasound. We use a MRI-guided focused ultrasound therapy. And this is the future. And the future is already there in Coimbatore. We are using this modality to treat Alzheimer's. We are using this modality to treat Parkinson's disease, which is also another degenerative disease of the brain. Now, these are the various new MABs that are coming: bapineuzumab, solanezumab, gantenerumab, ponizumab, and crenezumab. And all these, again, as I told you, need opening up of the blood-brain barrier. And so with opening up of the blood-brain barrier, using all these two new monoclonal antibodies, I think, or we expect in future, that there will be a real treatment for Alzheimer's disease. As India ages and as the number of people in India increase, then naturally we will have increasing burden of Alzheimer's disease. And this future of opening up of the blood-brain barrier is already in Coimbatore. I would also like to show you some of the things which we have used with MR guided focus ultrasound. This is the machine, this is the MRI, and this is the transducer which focuses ultrasound. You can use a lower frequency. What we use in Parkinson's disease, 650 kilohertz. In amyloid, in Alzheimer's disease, you use 250 kilohertz. When you use 250 kilohertz, it does not destroy the brain tissue, but it opens up the blood-brain barrier. Now, this blood-brain barrier opening is not only helpful in Parkinson's, it is also helpful in Alzheimer's disease. And here, what we do in our hospital is we use this machine to focus ultrasound waves on a particular part of the brain. Brain, as you know, is an electrochemical organ. When there are loss of dopamine in the brain, it produces Parkinson's disease. Some circuits in the brain become overactive. We destroy these circuits via means of focused ultrasound. 700 to 900 focused ultrasound waves of 650 kilohertz. I told you for Alzheimer, it is 250 kilohertz. For Parkinson's, for destruction of tissue, it is 650 kilohertz, are focused on a particular area of the brain, and we result in destroying these circuits with sub-millimeter precision. And this is how we do the procedure exactly. We use advanced brain imaging systems to calculate the targets. We use these 4 stages of treatment, and by this treatment we destroy exactly the circuits. Especially what we are doing here is we are destroying what is we call the pallido-thalamic tract. Movement disorders and Parkinson's disease especially is a rising concern, not only all over the world but also in India. And we are nowadays using this modality, and soon this modality would also be used for the treatment of Alzheimer's disease. I would like to show you only a few cases here. This is essential tremor. I would just show you one case of Parkinson's disease, which had severe tremors and which disappeared on focused ultrasound. I'll just show you one case and I will stop. And this is a patient with essential tremor who is not even able to put a pencil on the paper. He cannot write for the past 15 years. He cannot feed himself for the past 15 years. Got severe tremors. We take him up for this lesioning surgery, totally non-invasive, which does not involve general anesthesia, which involves only local anesthesia. He cannot write. We do this modality and he writes immediately. This was done in 8/8/2022. We have not done 105 cases, and soon we might be employing this technique. This he has never done in his life, and this a selfie he was never able to take before this insult. Now after the treatment he is able. So we are treating. This modality is available in Coimbatore. The future is now available in Coimbatore, and soon we might see an explosion of this modality in treating not only Alzheimer's disease but also stroke, epilepsy, and brain tumors. Thank you one and all for patient hearing and also giving me this opportunity. Once again, I thank the President Secretary of IMA-AMS for having given me this opportunity to share my thoughts on Alzheimer's disease and other neurodegenerative disorders, especially Parkinson's. Thank you.
Thank you, sir. Thank you very much for the excellent presentation. Dr. Valavan, sir.
Sir, thank you, Vijayan, sir, for the exhaustive and enlightening lecture, sir. So at least you came with some few encouraging words. There are some vaccines available and some disease modifying agents like aducanumab are available. Probably in the future, we can get more number of disease modifying therapies. As of now, we are having only symptomatic therapy for dementias, especially Alzheimer's. But probably in the near future, we may get disease modifying therapy, which can arrest the progression of the dementia. Thank you, sir. Thank you very much, sir.
Any question, sir? Valavan, sir? Impact of
sir,
COVID disease and COVID vaccine in neurodegenerative diseases.
Excuse me, sir. COVID vaccine.
Yes, COVID disease and COVID vaccine on neurodegenerative diseases.
No, sir. I don't think there is any evidence for COVID vaccine as such in the development of neurodegenerative diseases. Yes, a few cases of cardiac myocarditis was reported. I myself had one episode or minor episode. A few cases of GBS was reported. A few cases of increased seizure frequency was reported, especially in pediatric age group. Few cases of myositis was reported, but I don't know of it's in
Sir,
degenerate.
any dystonia, sir? Dystonia.
Increase in the number of dystonia following COVID? No, sir, I have not seen.
Vaccine, sir. Vaccination.
Vaccination for dystonia.
இல்ல டிஸ்டோனியாக்கு வேக்சின் கேட்கல கோவிட் வேக்சினால டிஸ்டோனியா
No, sir. I have no experience seeing any case of dystonia with almost. I would say it's very low following COVID vaccination. That much I can tell you. Vadavan sir, do you have any experience?
No, sir. So, as you said, GBS we are encountering, sir. A few cases of strokes we encountered, sir.
Yes, stroke.
Sir, as a one personal question, sir. Sir, which is the best screening tool you are following to detect dementia in the OP duty hours, sir?
Clinical. The best screening
Clinical only.
clinical only. Assess memory functions. That is the best.
Sir, apart from Alzheimer's disease, can we use cholinesterase inhibitors in other dementias like Parkinson disease dementia and vascular dementia and PSP like that? Can we use it, sir?
Yes, it can be used. Cholinesterase, especially cholinesterase inhibitors are also found to decrease the number of falls in Parkinson's disease and other degenerative disorders. They can decrease the number, though technically, pathophysiologically, it is actually counterproductive while using cholinesterase inhibitors in Parkinson's and other degenerative. But actually, it reduces the number of falls, so it can be used.
The one more question. Does tobacco smoking reduces the neurological disorder, especially Parkinson's?
So there are two views regarding this. One, the initial thing was something, a substance in nicotine was supposed to be protective. Now that theory still is there. I have a slightly different take on this. Like, I feel that tobacco users die early so that they don't develop degenerative diseases. That is the reason why maybe it has a protective effect. Or Parkinson's disease patient or people who are destined to develop Parkinson's other neurodegenerative do not smoke. Why they don't smoke? Because you know that the pleasure chemical in the brain is dopamine, and this reduced dopamine may be there decades before even the onset of clinical symptoms. So I feel personally, it is my own theory that these people do not smoke. So people who do not smoke or have a dislike for smoking, maybe you can watch them. They may develop Parkinson. Another thing is smell. If your sense of smell is very low, and if you have a dislike for smoking, not that people who do not want to smoke, it is people who dislike smoking may be at higher risk for Parkinson's disease.
Okay, sir. Is cerebral atherosclerosis is the root cause for neuro disorders?
Cerebral atherosclerosis is one of the causes for neurological disorders, not the root cause. No, vascular burden may be added on to Alzheimer's disease. Now, we have a Hutchinsky score which can differentiate a vascular dementia from an Alzheimer's dementia. But you must basically remember that Alzheimer's disease starts with memory, impairment of memory, while vascular dementia doesn't start with impairment of memory. Memory can be sometimes preserved well towards the end stages in vascular dementia and other dementias. Alzheimer's disease primarily starts with impairment of memory. Another form of Alzheimer's disease called the Benson syndrome, which is a posterior form of Alzheimer's disease, that starts with impairment of visuospatial recognition. Now that starts in the posterior temporal parietal lobes. Now Alzheimer's disease starts in the temporal lobe, medial temporal.
Okay, sir.
Another question, sir.
Yes, sir. Yes, sir.
Is there any role of botulinum in neurological disorders? Another question from audience, sir. Any role of injection Botox in neurological disorders now?
Botulinum has a wide role for application in neurological diseases. Take, for example, headache, to blepharospasm, to hemifacial spasm, to cervical dystonia, to writer's cramps, and so on and so forth. It has a wide role. Even for crocodile tears following Bell's palsy, botulinum has a very important documented tool for use in neurological disorders, not for dementia, including headache, chronic migraine also. Botulinum is a very useful tool.
Okay. Any specific
Another question from audience, sir. Yes.
Sir, any specific biomarkers for neurodegenerative disorders?
That's what we told you about the biomarkers. The very important biomarker, which is available only in the higher centers, I mean tertiary centers, teaching centers in India, is the tau protein, amyloid A beta and tau protein estimation in CSF. Other biomarkers, other markers are the imaging markers, which is widely available all over. Especially if you see in PET imaging, there is a reduction in the metabolism in the temporoparietal regions. That is very classical. Bilateral temporoparietal regions asymmetrically, very classical of Alzheimer's.
Okay. Does use of blood thinners and statins are as prophylactic protect the neurodegenerative diseases?
Statins are a controversial topic, sir. Statins known to sometimes enhance dementia, just like there is a statin-induced diabetes within inverted commas. Similarly, statins can worsen the brain functions, dementia. So I'm of the view that statins should not be used for all people, only in selected persons, especially with atherosclerotic risk factors or ones who have suffered from MI or any other peripheral vascular disease or stroke, then statins can be used. Otherwise, as a blanket therapy, I am against. Vadavan sir, your opinion on this?
Yes, sir.
Neurologists
Statin-
are against statin most of the time because it increases the chances of dementia.
Yes, it decreases the cholesterol level in the blood vessels, thereby producing various side effects, sir.
And Alzheimer's disease is diabetes of the brain, and diabetes is Alzheimer's disease of the pancreas. In pancreas also, in diabetes, you have amyloid deposition. So basically, pancreas is so both can be worsened by using statins. So blanket use of statins not recommended. Of course, if you have a vascular risk factor, yes, definitely statins are used. Blood thinners, no role for primary prevention. No role for primary prevention. If you have 1+1 risk factor, for example, if you have an uncontrolled diabetes, hypertension plus a smoker, then you may initiate these patients on low dose aspirin. Otherwise, there is no role for primary prevention in stroke as well as MI, I believe.
Sir, what age we have to do screening for Alzheimer's?
Excuse me?
What age, sir? After the age of 70 or something like that? What age?
Are you asking about aspirin?
No, screening
Yes,
for Alzheimer's.
Sir, screening for
Alzheimer's.
neurodegenerative disorders, Alzheimer's.
Anyone above 50 years, 60 years of
50,
age.
50.
Okay, thank you, sir.
Any role of older drugs like persentin and complamine present neurological disorders?
Presentin and complamina, these drugs are hemorheological agents, sir. Blood is a non-Newtonian fluid. So by reducing the viscosity, you aim to improve the blood flow to the smaller blood vessels and the arterioles and ultimately the tissues. That is the idea of using these. That was the idea of using these drugs, and these drugs, including dipyranol, they came of much vogue in the 90s, I believe. But now they don't have a proven role in the management of Alzheimer's dementia or Parkinson's disease. But I believe that if somebody uses it and is found benefit, no point in discontinuing. You can continue. They are very safe drugs. All is fair in love and dementia.
Trimetazidine, sir?
Trimetazidine in dementia, madam?
Yes, sir.
Sorry, madam, I don't have any personal experience. I don't also know about trimetazidine in dementia.
Okay. Thank you, sir.
Is it advisable to stop watching
Vijayan,
television
sir.
in Parkinson's patients? Is it advisable to stop watching television in Parkinson's patients?
No, sir, I don't think it is advisable to stop watching television. Television can be watched. I don't know how television is going to. Television will affect epilepsy, but especially flashy videos can affect epilepsy, but I don't see how it affects Parkinson's. If it is a brain stimulating program, why not?
What age you can expect Alzheimer's and any prophylactic treatment for that?
The prophylactic treatment is lifestyle modification, sir. Use your brain, otherwise you will lose it. So brain stimulating programs use, for example, the commonest thing is playing Sudoku, reading as a habit, not only reading as a habit, as a hobby, gardening, keep yourself mobile, exercising, especially cycling is found to have some impact on most of the neurodegenerative disorders, including Parkinson's and Alzheimer's. Cycling somehow favors the improvement of the neurochemicals, small neurochemicals in the brain, acetylcholine, dopamine, etc. Over and above other exercises, yoga will help you improving the balance, and these lifestyle, increasing fruit intake, reducing saturated fat intake, not taking alcohol, stopping
Swimming helps.
smoking. Sir?
Does swimming helps?
Excuse me, swimming, yes, sir, definitely. Definitely, any activity helps in the improvement of the brain function. Swimming definitely helps in the improvement of brain function, yes. Cycling is supposed to be very useful. We can promote that.
Yes, sir. There are so many comments that both the talks are very excellent and very informative, sir.
Thank you.
Thank you. Moderator, Dr. Valavan, for your final comments on this session.
Vijayan sir, thank you. Thank you for your exhaustive lecture, sir. And question answer section. And so you answered many newer things to our audience and to me, sir. It's very informative for both the audience and to the moderators like me, sir. So thank you very much for your time and presentation, sir. Thank you very much, sir.
Thank you.
Yes, sir. Jayaraman, sir.
Okay, good evening. We had
a
a wonderful
thanks.
discussion. Thank you, Sendil sir. We had a wonderful discussion to commemorate World Alzheimer's Day and the World Rabies Day. I thank my friend Dr. Vijayan, so wonderfully discussed in detail about the neurodegenerative diseases of the brain, mainly the Alzheimer's and the dementias and the Parkinson and all. The beautiful, crisp and clarity presentation, Vijayan. So thank you very much. And a wonderful moderation, Dr. Valavan sir. A lot of take-home messages from this subject. So thank you all. And I thank you, Dr. Syed Mohammed Buhari sir, for the wonderful, crisp and clarity presentation on rabies diagnosis and prevention and treatment modalities, and the nice moderation of our Vice President of National IMA, Dr. Gunasekharan sir. And thank you, more than 200 audience for very good interactive sessions. So thank you all, and thank you leaders once again. So we'll meet again next month. May I request everyone kindly take part. 13th of September, we have IMA, TNSB, AMS South Zone Conference. Similarly, IMA is organizing. Kindly take part. This is a Zoom meeting only. So there is a TNMC credit points of 2. And 15th September, we have a National IMA AMS conference at Chennai Green Park Hotel. So I welcome everyone. Kindly take part in this AMS program. So thank you all. Long live IMA, long live CCI. Thank you. We'll meet again in the next program. Thank you very much.